be the moderator for this webinar. This is the Small County Fiscal TA Mental Health Budget webinar with Mike Geist. And in a moment, I'll hand over the presentation to Mike. I just have a couple of housekeeping things. First of all, we are recording this webinar. So if you need to view it again, or if you'd like to have your colleagues view it and hear it, it will be on our CIMH YouTube channel within a couple of days, and you'll receive a link to the recording so that you can view it when it's available. You are all currently muted, but Mike will be pausing on a regular basis to ask for questions. So if you have a question, please type it into the question box, or you can also click on the hand icon next to your name, and that will let us know that we should take you off mute so that you can ask your question. And you should all have received the materials for today's webinar via email, but if you don't, please send me an email at szatz@cimh.org, or type your question to the question box and I'll send you the materials. I think that's it. So here's Mike.
All right, thank you, Shoshana. So what we're going to cover this afternoon is a little broader than what we typically do after the Financial Services Committee meeting. So probably about the first hour or so, we'll just go through the Financial Services Committee meeting and cover the issues there, which is basically all the bulleted items that you see there. And then the second hour, if we need a full hour, we were going to go through each of the different revenue sources and what the revenue projections are, and give you kind of some tips on what you might want to look at from a budgeting perspective going forward. So again, most of these topics are what we discussed at the Financial Services Committee meeting last Thursday on February 6th. So diving right in, I'm going to start with the update that we had on MHSA issues, and probably the one that's the most important is this update regarding the revenue and expenditure report. And given all the issues that we've incurred trying to complete the 11-12 revenue and expenditure report, CMHCA, well, and as we've recommended to you folks to look at the forms, and if you see that you are having funds revert, you may not want to show that, and there were certain ways around that, either not including unspent funds from prior years or not even completing the unspent funds template. Given all these issues, the state started to push back on some of these counties, and we've kind of felt we needed to get this resolved because we need to be able to submit something that's acceptable to the state while at the same time accurately reflecting the financial position of the county. So we went ahead and real briefly provided some high-level comments regarding the calculation of reversion that was in the template. And there were really three major ones. One had to do with putting PEI funds into the prudent reserve after fiscal year 07-08. And my understanding is that's being addressed by the legal folks right now. The other problem on the form itself was that it didn't calculate innovation consistent with the state's policy. So even if you didn't have innovation funds reverting, the form itself did not reflect that, and it didn't reflect their own policy. And then the last thing, and that we really haven't had much of a discussion with the state about, is just how they're treating other revenues, specifically looking at how they're treating interest, as well as how they're treating primarily FFP. And again, the way that they've set the form up and requiring you to tie back to prior year unspent funds amounts, well, some of those unspent funds could have been interest, for example, or FFP. And so we asked them to at least give us a chance to work with them and take a look at those issues, and they agreed. So we are going to look at these reversion issues outside of the revenue and expenditure report. Some other concerns that were expressed in the meeting itself had to do with the level of detail on the unspent funds page, and trying to get your auditor controller to certify really the amount of unspent funds available from each of the various fiscal years that they were identifying. And so we'll be addressing that hopefully as part of this process. So DHCS, and we'd reported on this before, they agreed to form a work group to look at the revenue and expenditure report, and CMHDA recommended using the cost report work group with a couple of other folks to provide input into that process based on the issues that counties had in completing the 11-12 revenue and expenditure report. DHCS then said that they were willing to revise and reissue the template for 11-12 by the end of this month and allow counties to resubmit the revenue and expenditure report. So again, so that we can get this kind of taken care of. They indicated they were going to take off the reversion parts, so that should no longer be an issue, but we still may have the issue around the level of detail on the unspent funds page that we'll have to work through. And then finally, this work group will continue to meet to resolve additional issues, going into 12-13. The template obviously isn't out. And some of those other issues that I mentioned around reversion and how the state's going to treat those in the revenue and expenditure report, if they're going to use the revenue and expenditure report for reversion, which I believe they intend to do, that will then have an impact on what the future templates look like. But at this point, if you're getting pressure from the state analyst who maybe hasn't heard from management that they're going to be issuing a new template for 11-12, I wouldn't worry about trying to get it complete, the 11-12 complete at this point, and I would just hold off until this work group meets and we get this revised template out. Anybody have any questions on that? I think it's good news, so hopefully we can resolve some of these issues and again have this work group look at some of the longer term things, which also longer term I think includes looking at how to develop the interrelationship between the revenue and expenditure report and the cost report. So no questions? Good. Moving on to additional. Okay.
Sorry. There's one question. Do we need to redo a report?
Yeah, so at this point I wouldn't do anything, and so until this comes out and instructions come out, I would not do anything with respect to the revenue and expenditure report. We'll hopefully know better by the next Financial Services Committee meeting in March, whether basically what I could see happening is that you have to go in and, because I don't think the component detail pages will change unless there's some other issues that I'm not aware of, that it's really just the unspent funds page that would change, and so hopefully the state would have a way to make that work without having you have to go through and re-enter all the data. But at this point that's purely speculation, and I mean we'll also see if they can if this even gets accomplished by the end of this month. Because even at this point, I haven't seen anything about the work group getting together. So,
another question. Any hints yet about how long we'll have to complete the new RER?
At this point, again, no idea. But assuming that the component pages don't change, and then it's just the unspent funds page that changes, there hopefully isn't that much work. And if anything, some of the stuff on the unspent funds page may be rolled up, I think would be our suggestion. And so it may be, especially if we've already completed the template, it would hopefully be a fairly easy process then to incorporate the data. But again, at this point, that's speculation, and until the work group actually meets and we go through the issues, I don't know what it's going to look like, and so hopefully we'll have more information in March. But you know, we always try to push for as long as possible. You know, 60 days, 90 days. Recognizing we want time to get it right, but again, it hopefully isn't that much work if you've already done what exists currently.
Okay, that's it for now.
Okay, moving on to a couple of other issues. We talked a little bit about the distribution formula, which has basically stayed the same ever since we had a dip in revenues, and I forgot what year that was. I want to say 10-11. So we really haven't had an update to the formula since 9/10, since the last year of growth that was anticipated growth. And there's been just a general agreement between the state and the counties and CMHCA that the state would not change the formula until there is growth above the highest prior year distribution amount, which now is 1213 rather than the 910. And so the other part of that too is that CMHDA, one of the principles we always have typically on distributions is that if you're going to modify the formula, the modifications would only apply to growth so that everybody's base stays the same, so that you're not totally redoing the way the funds are allocated, and we'd only be talking about applying a different percentage distribution to the growth. DHCS wouldn't go as far as to commit to that, but I think we'd push pretty hard for that, especially since that forms the basis for how you're doing your 3-year plans and everything else. So apparently DHCS has updated the data that was previously used. They've done that internally, but at the same time, a lot of that data doesn't necessarily make sense, especially the uninsured population, which was a factor in that that prior formula, given that now we've got the Affordable Care Act. So I think it would really take some looking at whether the formula that was previously used is still really applicable given some of the changes that have occurred. But that said, I think we still want to have something in place should we actually see some growth. So it would be that kind of similar to the realignment funds, where you basically get funded up to the amount of the highest year, and again 1213, and then to the extent that there's funding above that, it would be distributed with a different percentage. So we'll start having those conversations with the state, and I would imagine at some point we'll probably put together a work group so that individual counties have the ability to provide input into how the growth funds are distributed. But you'll also see when we go into the budget stuff later that we really don't think that we'll be above that 1213 amount till at least fiscal year 16-17 or maybe even 17-18. So it's something that's good to do, but there's no real rush at this point to get it in place. The other thing that the state brought up is that they're really pushing on this evaluation for MHSA, and that they are looking to the CSI and DCR data. As part of that, they forward the data onto the Oversight and Accountability Commission, who somehow then is using the CSI data. The DCR obviously is applicable directly to MHSA because that's the full service partnership data, while CSI is much broader. So we're not totally sure what Oversight and Accountability Commission is doing with the CSI data. But the good news is that pretty much almost everybody's current, within a month of submitting both CSI and DCR data. So that's good to see that counties are becoming more current with the reporting of data. And if you're not sure where your county is, there is, in terms of reporting, there is a status report shown on the DHCS website under, if you go DHCS Services, Mental Health, there's a data and reporting link, and you can see both, I believe there's a separate report for CSI and a separate report for DCR to see whether you're current in submitting that data or not. And then the last thing to do with MHSA that we talked about was the performance contract. There is a performance contract now for MHSA. To date, I guess DHCS has received 17 of those contracts. The counties do have some concerns, especially around the HIPAA provisions, and so has involved the County Council Association in the review of those performance contracts. And that was it on MHSA. Anybody have any questions on those things? All right, then we went into kind of an interesting update on drug Medi-Cal. So the budget that was just released by the governor's office includes some state general fund monies for the new benefit of expanded drug Medi-Cal services, and that's for residential and intensive outpatient services. Apparently, DHCS does not have approval from CMS to implement these services yet. They've submitted a state plan amendment or are in the process of doing that, but they don't have approval, and so they can't pay for those services yet. They indicated they need to amend the county contracts for these expanded services. In addition to the services, they're looking to amend areas around county oversight, authorization of services, and then update the payment rates. And where it really kind of got confusing was in discussion that the state DHCS is not going to pay any drug Medi-Cal claim file, in other words, the entire file that includes these expanded services that have a little bit of the state general fund associated with them. So they will basically hold the entire claim file pending the approval of the state plan amendment so that they can pay for these services, as well as the amendment of the actual contract with the county. So it sounded like the claim would be adjudicated but not paid, and so it would just sit at the state pending these two issues. And so what that means is if you submit a claim file, the whole thing is going to get held up, irrespective of whether you've got existing approved drug Medi-Cal services. As long as you have some of these expanded services, it would hold up the entire claim. They did, and they kind of went back and forth, so it was kind of a confusing conversation. So they did agree to provide written guidance. When I looked earlier today, I hadn't seen anything on their website under the substance use disorder bulletins. More than likely, they're going to have to provide a delay reason code for these services. And this is effective for services provided beginning January 1st, 2014. And so what CMHDA recommended is that the SWAT team be involved with this, and that the state use the short Doyle 2 calls to provide both an update to the counties as well as to get input from the counties as this moves along. Anybody have any questions on that? I know it was, again, in the meeting, it was somewhat confusing. So definitely more to come.
There is a question, Mike.
Okay.
Is there also a problem with submitting claims with new beneficiaries with 100% FFP included with the old services that were pre-January 1st, 2014?
And so this is where it was really confusing. I don't think there should be, because they don't need a state plan amendment to cover the new beneficiaries. They just need a state plan amendment to cover the new services. And one of the representatives from DHCS said it just had to do with any of these claims that included the new services, which then included a state general fund share. So for those, if you submit claims that do not include the expanded services, but do in fact have the beneficiaries that are now covered, the new beneficiaries, I don't think it's going to hold up the claim. But again, we'll wait for written guidance. I think it just had to do if you had somehow had a service in there that included the expanded service that includes a state general fund reimbursement amount, that would cause the entire claim file to be held. But again, we need to see the written guidance, and that was just my interpretation of what the person or the people from DHCS indicated on the call.
Another question. Is there software changes that need to be made for higher FFP?
No. It's well, the software changes would be so it's just the aid code that dictates the 100% FFP, whether it be in the drug Medi-Cal program or the Medi-Cal specialty mental health program. There are certain aid codes that your system needs to be able to accommodate that would result in the 100% FFP. But it's not, the higher FFP has nothing to do with services or the actual change in services. So hopefully your vendors have already done that and incorporated the additional aid codes into the systems. Because again, it would impact both drug Medi-Cal and especially mental health Medi-Cal. All right. Again, a lot more to come on the drug Medi-Cal. So then we got into the new billing feasibility system study that we've been talking about for a while. It does seem to be finally getting a little bit of legs in that CMHDA and DHCS are going to work together to construct a project management plan for a new Medi-Cal special mental health reimbursement system. And really it's looking at kind of restructuring the fiscal process rather than relying on a line-by-line claim approved to get an interim payment of FFP. This would be a different process. And so this project management plan will draft out in pretty high-level detail what that could look like. This would then be pilot tested, meaning just, or you might even want to say beta tested, to see what the impacts are, both on the HCPC and CPT codes, because we're looking at probably going to more of a CPT code approach, getting rid of service function codes, getting rid of minutes of service. And then so take a look at that, see how it also impacts the cost report. Obviously that would be a significant change, and there's a couple of different ways to go in terms of how the cost reporting would be done. And then also just the impact on data systems. And so probably we'll be talking next couple of months about trying to get some counties who want to volunteer to see if this works or would work within their county and provide input into the process. There's, and hopefully you've heard about this, the MITA, the Medicaid Information Technology Architecture, and DHCS is going to come and provide a presentation at the March Financial Services Committee meeting on what that really means and what that looks like. Cal Mesa is managing the process of this study, and I've put Sarah's email there if you have any questions or need additional information. And they're basically responsible, when I say managing, they're administering the process as well as providing the fiscal infrastructure for the process, which includes invoicing counties for the different share of funding that each county has. They're also going to assist to the extent there is a future procurement down the line. And then they're hosting the county calls for counties that have questions. CMHA had drafted both short and long-term strategies. Again, some of the short-term strategies are what I'm talking about in terms of getting rid of service function codes, those sorts of things, versus a more longer-term strategy, which actually feeds into the next bullet. The short term is that short dole 2 is still going to be around, and it's probably more than just another year. It's probably maybe 2 or 3 years, maybe even 4 years. And so that's kind of what we're saying is the short term. And then the longer term would really be incorporation of the behavioral health data system into the overall Medicaid system to allow for interoperability between both behavioral health, primary care, physical health, all the other systems, so that there really is just ultimately one system for a state Medicaid program. The initial focus on this is mental health, but at some point there's probably going to be some opportunities to look at incorporating drug Medi-Cal into the process, especially as drug Medi-Cal moves forward with potential waivers and other things. The MITA process itself, which is really a focus on business process, really forces the state to start to consider integration, and they really, CMS through the MITA process doesn't want a standalone behavioral health claims processing system, that they want an integrated, interoperable system from the state. So as part of going through this, if CMS agrees that the state followed the MITA process in the approach, there's a good chance we would be able to receive enhanced FFP for this project, so that we would get, I believe it's 90% FFP for developing a new system. And Cal Mesa indicated they were going to have another county conference call here in the near term. So hopefully that will happen soon, so that folks with questions can get their questions answered. So any questions on the new billing feasibility system study or new reimbursement approach? That again, it's a ways out, but and we'll definitely at the CIMH May Fiscal Institute, we'll probably be getting into this a lot more detail. Okay, and we went into the short DOIL 2 updates. Hopefully you're aware that DHCS issued Information Notice 13-24, which describes the process for obtaining health plan certification for services that are not covered in a Medicare Advantage plan. So the Medicare Advantage plans that are health plans that don't cover specific services, you can now, through this information notice, which also includes basically a draft template that you can just ask the health plan to submit, that they can go ahead and complete that. And what that means is you don't have to first bill Medicare for those services provided to beneficiaries covered by the Medicare Advantage plan. At the time of the meeting, DHCS had only received one letter from San Mateo, and DHCS indicated they will post the health plans once they receive a certified letter, so that you can look, and if you have a Medi-Medi beneficiary that is in one of the health plans that is listed, then you don't have to bill Medicare. Apparently the letter needs to be submitted annually based on the health plan's contract fiscal year. The nice thing, though, is that the health plan only needs to submit one letter for all of the enrollees that are covered by that health plan, even if it crosses counties. So not each county needs to get a letter from every health plan for which they've got a Medi-Cal beneficiary in the health plan. And what San Mateo suggests is that counties who are looking to do this, you should probably start with the health plan's provider relations manager, because contacting the Medicare Advantage Plan in general may not, they might not be aware of this. So, but the provider relations manager seemed like a good place to start if you're looking at trying to get the letter completed from the health plan. Any questions on that?
There is a question about the web link that would allow people to check the county status on FSP reports. Do you know off the top of your head what that is? I can send that out.
The web link to check DCR and CSI status?
Is that right? Is that what you're talking about, Karen? Yes. She says yes.
Yeah, I can get that to you, Shoshana.
Okay, and I'll send it out.
All right, so moving on to KDA implementation. Supposedly DHCS is posting a report on the number of claims and dollars and everything else that they've received. I have actually not been able to find where this report is, so on DHCS's website. So I'm not sure where they're posting it. They've been obtaining input from stakeholders on the content of the report, and so they went through the information that's shown on the report. But there are still some issues, and so right now at this point there's only been 17 counties that are submitting the claims with the KTA indicator on them, and so CMHDA again is saying you really need to work with your vendors to make sure that you can get these indicators into the claims, because it's important both to report back to the courts that counties are complying with the judgment or the settlement. I'm sorry, and as well as this potentially feeds into a Prop 30 claim. So you definitely want to work with your vendors to get these indicators so that your claims can reflect the services provided to the subclass. I guess Los Angeles County has identified an issue with the secondary modifier related to telephone, and I don't really know a whole heck of a lot other than that DHCS said that they're working that through their policy work group. So they're aware of the issue and they're working on it. And then we talked a little bit about the therapeutic foster care, which is a new service that's still waiting CMS approval of the state plan amendment for services. And it would define both the services and the reimbursement methodology for the therapeutic foster care services. DHCS anticipates submitting a formal SPA, state plan amendment, before the end of this quarter, so before the end of March. And by doing that, it would make it effective back to January 1st, 2014. And so the other thing we talked a little bit about is if some of your contract providers are really pushing you to contract with them and expand services for this therapeutic foster care, really the position should be at this point, because the state doesn't have approval of the state plan amendment, we don't know what the reimbursement system is going to look like, that really just to hold off until some of these other issues are taken care of and further resolved so that you can structure your contract appropriately and provide and pay for the services appropriately. And that was it on KDA. Any questions?
Hold on.
And don't get too technical on me in terms of a systems question.
There's a question that is actually going back to your previous topic. Did they mention drug Medi-Cal in relation to the letters?
They did not. And I assume it's the Medicare Advantage Plan is what we're talking about. And I didn't look at that notice that closely to see if it did include the drug Medi-Cal services. So we're going to have to, I'll have to check that out, and maybe when we send out the CSI link, I'll give you an update, unless anybody on the phone knows off the top of their head whether that info notice covered drug Medi-Cal as well as Medi-Cal, especially mental health. Yeah, so we'll have to get back to you on that one. Then going into claims payment update, talked a little bit about the 910 cost report settlements. They've received a bunch of the reconciled cost reports. They didn't indicate how many, but it sounded like most counties have submitted reconciled cost reports. And so if you haven't, you want to get that done as soon as possible. DHCS is working on the settling the cost reports and putting together the settlement letters, and they anticipate, based on the counties that have the reconciled cost reports, that they will be able to issue the settlement letters by March 7th. So a little less than a month away, we'll start to see settlement letters for 910. We talked a little bit about the 1011 cost report settlement. And so in 1011, this was the first year that they had revised the cost report, and specifically the MH 1963, to deal with provider payments, to really show the certified public expenditures, and recognizing that that counties settle with providers after after submission of the initial cost report. You actually are allowed to modify that section of the cost report as part of the settlement process. So in order to allow you to do that, they've increased the timeline. I believe it used to be 45 days, and so they're now giving you 90 days to go ahead and reconcile your cost report and submit it back to the state. And they anticipate, once they get the 910 out, that right away they will turn around and issue these reconciliation letters for counties who have a 1011 cost report that has passed all the edit checks. And so then you'll have 90 days from then to go ahead and reconcile your cost report and upload it back into ITWS. They indicated that if a county submits their reconciled cost reports or uploads their reconciled cost reports in April, that they were going to try to have settlement letters out to those counties by the end of this fiscal year. So depending on how difficult your reconciliation is, will dictate whether you end up with a settlement letter this fiscal year. Obviously, to the extent a county is owed money, that would not be paid in the current fiscal year. So I don't think you can count on receiving 1011 settlement if you're owed money in this fiscal year. I just don't think the state's going to get it done that quickly. But just go ahead and, at least if you're aware of the process, you can kind of be prepared and look for those reconciliation letters coming out in March. And then we talked about how the state is now emailing electronic accounts receivable invoices to the counties. and apparently that seems to be working good because some counties said yes, they're receiving them. And so that is part of the new process of letting you know when you owe funds back to the state. Before I go to the next page, is there any questions on any of this stuff? All right, so kind of continuing on that same line, the state, DHCS, is moving towards an electronic funds transfer process of paying counties instead of paper warrants. So you would receive an electronic funds transfer rather than a paper warrant. I guess the state controller's office is in the process of testing that at this point. And the state wasn't totally sure, but they said within the next couple of months they thought they would be able to go ahead and fully implement this process. And as part of that process, they'll issue an information notice, and counties will be given the option, apparently, about whether you want to opt in to the electronic funds transfer process or whether you want to continue to receive paper warrants. So it's not automatic that they're going to do this, but you'll have the ability to opt in based on what they've said so far. But we'll look for this information notice to let us know more about that. And we talked a little bit about the warrant intercept, or what is often commonly referred to as the green sheeting process. And they're moving from paying you full amounts and then doing these green sheets and intercepting warrants to actually giving you a warrant that is a net amount. So what they'll do is they'll net the outstanding accounts receivable invoices against payments due the county. So rather than intercepting a warrant and reissuing a different warrant, they would just net it out of the warrant. So that should make it a little easier to track and follow. They're going to this netting process regardless of whether a county opts into the electronic funds transfer process. So if you decide to stick with paper warrants, it still should be the same thing where you're seeing a net amount on the warrant that should tie back to, the warrant number should tie back to the actual claims paid with that warrant. And then they said they'll provide sufficient details so that you can understand how the net amount paid was determined. I know that's been some issues in the past, is understanding what was being netted out. So hopefully they do provide enough detail to allow you to do that. And then one county brought up the option to go ahead and pay when you have an accounts receivable rather than having this netting process, especially with you've got a large cost settlement that may actually, where you've set some funds into a reserve to pay for that cost settlement, you want to go ahead and pay that out of those that reserve rather than having it netted out of current year funds. And what the state indicated is that that you do have the ability to go ahead and pay an accounts receivable invoice, I believe within 45 days, and then they won't initiate the netting out of the invoice from your current year payments. So I mean, it sounds like all this is going to be a good process, and we'll kind of see how it goes. But it sounds like it's moving forward, and hopefully we'll see it pretty soon. Anybody have any questions on it or comments? All right, moving to county claims reconciliation. And again, this is where counties have volunteered to have the state work with them on identifying missing 835 files. And so apparently DHCS has resolved many of these issues. There's now only 12 counties with about $9 million worth of missing 835 files. And I think the main thing, and this continues to be the issue, is that if you have the time to invest in looking at this, if you think that you're not receiving or haven't received the level of payment that you would have thought, you should probably volunteer to work with DHCS, and that's the Med-CCC folks. Get the data that they have, and so that you can see if there are any gaps in your system. But it does, in some cases, take quite a bit of an effort to do that on the county staff. And then we talked about this reconciliation of the inpatient managed care offsets, which are offset against your 1991 realignment payments. And somewhere along the line where we were talking about the state providing a database to allow counties to see individual county-specific claim level data, the state took that to mean that the counties wanted a statewide summary report. So they're apparently developing a statewide report, but really what the data that the counties want is the managed care data that's in the 134 file at the state with the fiscal intermediary. Counties want the actual data so that you can reconcile it with your TARs and verify, in fact, that the offsets are being performed correctly. So at this point, I'm not sure where this is going to go because a statewide report probably isn't going to give you the level of detail that's really going to be that helpful. So hopefully the state got the message, and we'll see if we can get it back on track to where they're giving you the 134 file data in a format that you can read. But we'll see. I mean, this has been on we've been talking about this for several years now. So, and then the last thing under claims payments is that DHCS did say that they're going to merge the mental health information notice process with the substance use disorder bulletin process into a single process, so that you can go to one spot to look for all whatever you want to call them, bulletins or notices. And they weren't sure if they were going to take historical bulletins and notices and put them all together, or if it will just be the new bulletins. But in any case, even the old stuff is still on DHCS's website. You just have to hunt for it. But going forward, it will all be together. Does anybody have any questions on any of that? All right. Going into the state and federal budget update. So there's a couple of things here. Both mental health and substance use disorder prepare separate supplements to the state budget. Those are posted, and actually I'll probably, when we do the CSI DCR website link, I'll give you the link to that as well. It's under the Medi-Cal estimates on DHCS's website. And the state indicated that the mental health budget supplement and the data there are based on claims data through last June. And I'm going to talk about this more in the budget stuff, but there are some interesting things that they're showing. And but since we're basically for mental health no longer state general funded, it's not as much of an issue. So we didn't spend a lot of time on that. We did talk about there is a little bit of growth, 10.7 million, that is supposed to go to the 1991 mental health realignment fund from 1213. And again, we'll talk about this more in the budget stuff, but this is that 5% of the growth in the support services account of the 2011 realignment, 5% of that growth goes to fund 1991 mental health realignment growth. It doesn't change the base or anything, but it is, additional monies that are supposed to be distributed. And when I looked this morning, the state controller's office website said that amount was still pending. So the state thought that maybe that had been distributed, but I don't believe it has been to date. And and so hopefully that will be going out soon, because there's really no reason to hold those funds. Unlike next topic, which is the 1213 behavioral health subaccount, there's $27.8 million in 1213 growth there, and CMHDA had recommended just using the existing percentages to distribute the funds, since there really aren't sufficient funds to cover all of the growth, even in just EPSDT. So they said just go ahead and push those out. It has no impact on the base again. On the individual counties base, it does impact the overall behavioral health subaccount base. But DHCS continues to want to look at approved claims, and they indicated they were going to try to look at the approved claims, I believe, through December, and then submit some sort of recommendation to the Department of Finance. And you know, again, our take is that the approved claims don't necessarily reflect actual costs. So anyway, we'll kind of see how that goes. It's not a ton of money, but obviously we're sitting here in February. It'd be nice to have the growth from last fiscal year distributed, so that you folks had it and could incorporate it into your budgets. And then we talked a little bit about the 1314 behavioral health subaccount allocation percentages. Really, the thing here is that hopefully you've all seen. In fact, I know you should have seen the letter, because we sent it out with the presentation, and that's this letter here. The problem is we don't have any of the detail behind how those percentages were calculated. DHCS has been saying for several months that they're drafting an information notice that will show how they came up with those percentages. And so for those of you who are using the state's information to identify how much of the behavioral health subaccount goes to substance use disorder versus EPSDT versus managed care, hopefully that information notice will provide that detail to allow you to do that. The other thing that we talked a little bit about was in your January distribution, you should have seen this SB 1020 adjustment, and we're pretty sure that purely is a cash flow adjustment, where they were putting too much money into the support services account. A higher percentage of the revenues that were being received were going there than should have been, but that it doesn't impact your overall base for 1314. So it's purely just a cash flow thing. We fully expect the base to be fully met in 1314. So it's just a cash flow issue. And again, I'm going to go through these in more detail when we start looking at some of the numbers in the budget section in the second hour.
There's a question. When you are talking about the growth, can you give a brief description to those of us just learning about this?
About the growth. So the state actually did receive, for 1213, additional revenues over and above the base that was established for the behavioral health subaccount, and that's the $27.8 million. The problem is they're required by statute to consult with CSAC, who is involved, CMHDA and CADPAC, into the process of determining how that growth should then be distributed among the counties. So there's $27.8 million sitting at the state, just waiting to be distributed to the counties, but they haven't been able to agree upon an approach for allocating those funds among the counties. What CMHCA, and I believe CADPAC's on board with this, although I'm not 100% sure, have said is distribute it based on the existing percentages that are used to distribute the base. So just go ahead and put it out using those same percentages. DHCS is more concerned about looking at claims data, because they want to make sure they fully fund the entitlements, and so they may be recommending a different approach to allocating the growth. However, they've also put out already the fiscal year 13-14 percentages for each county, and so this growth from 12-13 hopefully would not impact the percentages for 13-14 if they do decide to go through and allocate it based on claims data, which again is not necessarily reflective of actual costs. So I don't know if that's answering the question, but the bottom line is we've got some money that's sitting at the state for 12-13. It's there. It's just we just don't know how much each individual county is going to receive at this point. Any other questions? And again, we're going to look at some numbers in a little bit here, and I don't know if that'll make it clearer, but we'll see. So then we got into the, what's that?
Sorry, one more question.
Yeah.
Was the base established in fiscal year 12-13?
So for, yes. And in fact, I didn't put the information notice on here, but DHCS, I might have it later. I actually don't. So DHCS issued an information notice, so again, we'll give you that link, that describes how they established the base for 12-13. And so I should say two things. The behavioral health subaccount base is dictated, in total, is dictated by what's in statute. And so that amount was specified in statute for 12-13. It was then further specified how the growth for 12-13 would be distributed between the different accounts and sub-accounts, and that new amount, at least for the behavioral health sub-account, if you take the 12-13 base plus the 12-13 growth, that subsequently becomes the 13-14 base in totality for the behavioral health sub-account. What the statute further specifies is that CSAC and the state will work on how that base amount will be distributed between the counties. And so 12-13, DHCS issued an information notice that specified how that was determined for each individual county. In 13-14, DHCS and Department of Finance issued this letter, which came out with the handout today, and it's just one percentage, and we have no idea. I shouldn't say no idea. We have a limited idea in terms of how those were determined for each of the individual counties. And in some cases, the percent that goes to a county went down. And so some counties actually are going to receive less in 13-14 base than they received in 12-13 base. But the overall amount in the behavioral health subaccount was established in 12-13, and then it just keeps moving on from there. But how that is then distributed between the counties, the state keeps changing it. And again, one of the CMHDA principles is that you keep the base constant. Let 13-14 be the base so that nobody receives less than what they received in the prior year unless revenues overall are down. Otherwise, I don't see how you guys can budget for this. But we'll see if the state's willing to accept that recommendation.
Question. This is based on 2012-13 substance abuse subaccount allocations, yet this subaccount includes managed care and EPSCT. Is that right?
Yeah, so if you go to, and we'll get the link to you, the information notice for 1213 went through each of the programs that are funded by the behavioral health account that went into figuring out the percentage that a given county receives. And so it went through all the substance use disorder programs, drug Medi-Cal, drug courts, non-drug Medi-Cal, and there's a couple others that are part of this, as well as it went through EPSDT, which included existing EPSDT, the transition of the Healthy Families program from Healthy Families to Medi-Cal, and so that became EPSDT, and then also the KDA funding, and then also managed care. So it has all those parts are included in the behavioral health subaccount. DHCS said how those funds were basically determined in 1213 as part of the base in this information notice. And it's, I want to say it's 13, no, it's 12 something, but we'll get you the link to that. What they haven't done is given us that same level of detail for 1314 that they've just given us those percentages in the letter, and so we don't know how much is related to drug Medi-Cal. And I know this letter is confusing, actually. That's probably why this, because it says substance abuse subaccount allocations, and that's not correct. This is the entire behavioral health subaccount. That's probably where this question's coming from. So the state's title on this is not correct. If you look at how much you're receiving of the behavioral health subaccount, it's this percentage in total for all those programs, not just the substance abuse subaccount. That's probably where the question came from. So don't look at the heading on this. All right, going into the work group updates. They're continuing to work on the state plan amendment. They were, I guess some of the CMS folks were on vacation, but they're hopefully finished with their informal review sometime this week so that DHCS can have a call with them, get all the issues resolved, and then submit the official state plan amendment in March. And I should say the official one was actually submitted back in March of 2009. This would be the next official one that would then give CMS 90 days for a review. And that's why also this would be retroactive back to January 1st, 2009. And then the biggest thing here that we're waiting on is this whole supplemental payment process, which allows you to voluntarily submit a request for reimbursement of certified public expenditures that you incurred in excess of what you were reimbursed. And so there's going to be a form for doing that that hopefully comes from data directly from either the settled or, in some cases, audited cost reports. But once DHCS gets the approval, then they'll go ahead and release those forms, and you folks can go ahead and get the additional reimbursement. They also, CMS, when they did a financial management review back, I want to say it's 2009 or 2010, said that DHCS needed to come up with a training and oversight plan. And now DHCS is going to do that. And they want to know, they want some feedback from folks around what the training should look like regarding the cost report. So, you know, next summer, hopefully, for the 13-14 cost report, they would provide some additional training over and above what they've done in prior years, which is basically just how to fill out the, how to plug numbers into the spreadsheets. And we'll hopefully have some more content to that. And so they're going to talk to our CMHCA's cost report work group to get some input into that. The county's also suggested that they should talk to the auditors because if there are issues that obviously continue to come up with counties, that's obviously a deficiency that counties keep performing, and provide some training on how to not do that, or what are the alternatives, or what should counties be doing. And so I think that's a very good suggestion, and we'll keep tracking that as that moves forward. And then we talked a little bit about the 1213 Medi-Cal Special Mental Health Cost Report. The state has revised the detailed template multiple times, and I believe even as late as last week, as well as they revised a summary template. And what was kind of good news was that you don't need to use the most recent version of the template if you were not impacted by the change in the template. So the most recent template change probably impacted maybe 1 or 2 counties in the state that had a hospital that also provides Mode 10 services. Apparently there was some issue there, so they revised the template to address that. But if you're a county that did not have a hospital that provides Mode 10 services, you don't need to reuse or repopulate a new template. You can use the older template that you had probably previously completed. The prior version, which I think was released, I want to say late January, on the detailed cost report, apparently only impacted county legal entities, and specifically the MH1965 drop-down menu, where apparently line 24 was not being shown as available, and so they fixed that. So again, if you're not impacted by these changes, you are supposed to be allowed to submit an older version of the template and be okay. So, which is good news, so that you don't have to rework a bunch of stuff for something that has no impact on you. And then the last thing that was really positive is this whole issue around customary charges. What this is the state, and the states often refer to this as the published charge issue, but it's really the customary charge issue, where you're reimbursed the lower of costs or customary charges, or you can demonstrate that you're a nominal fee provider and be exempt from having to do the customary charges. What CMHDA has maintained is that there are provisions in the Provider Reimbursement Manual that say if a provider or a governmental entity doesn't have a customary charge, that you're allowed to get reimbursed actual costs, that you don't have to go through the nominal fee thing, that it's basically not applicable to a county or to a government entity that does not have a customary charge. And so they're saying that, yeah, their legal basically agrees with that, which is great. So they still have to get management approval and then discuss this with CMS. They would go ahead and then incorporate that into the proposed state plan amendment, so it would be retroactive back to January 1st, 2009. And I would imagine that they're going to use the process. So for cost reports that have already been filed, so basically potentially through 1213, they would incorporate the supplemental claim process to deal with those at least through 1112, and then maybe for 1213, since they haven't, actually I don't know, maybe they'll do that through the settlement process and just disregard, and they'll make some programming changes to what you would have already submitted. But in any case, this is all good news. It would mean that basically going forward from January 1st, 2009, as long as we're under a certified public expenditure structure, that your FFP would be based for the county operated providers would be based on your actual costs, and not subject to the lower of cost or charges. Mm-hmm. All right. We covered a couple of other fiscal issues. You know, we talked what happens if this fiscal SPA and the customary charge thing doesn't go through. what strategies are there, and obviously, you can set your rates, which again they're calling the published charges, which again isn't technically the correct term. You can set those above, significantly above your costs, depending on your political situation, to not even have to deal with this. But I think probably more importantly is if it's DHCS that says that they can't support this, then we may have some other options. But if it's CMS that says that they can't support this, then we're probably going to have to look at working with DHCS on how we structure the nominal fee exemption, and that the auditors typically, at least some of them, have been taking a much more stringent approach at looking at looking at the nominal fee provider exemption than even's written in the provider reimbursement manual. So anyway, there may be more to come, but we're just hoping that the state agrees that customary charges don't exist for government providers in community mental health. We talked a little bit about UMDAP. It is still in statute that you do the UMDAP, but it's not really enforced. And we talked, basically we kind of want to be silent on this at this point from a county perspective. There's no reason to bring it up because at some point there might be some statutory changes to eliminate it, but let's just not raise it at this point. We talked a little bit more about the performance contracts for the Mental Health Services Act, and again the issues were around the HIPAA, but apparently there's a bunch of new terms and conditions that the state's incorporating that the counties don't believe are relevant or applicable, and one of those had to do with procurement of equipment. So at this point, CMHCA is working with the County Councils Association to hopefully get a lot of that resolved and hopefully taken out of the contract. We talked about this excluded parties, and so this is a list that is published, and how often do counties check the list. Your mental health plan contract requires you to check periodically, but that's not really specified. That there are, it sounded like quite a few counties that are checking monthly, and that they're doing it for all employees. They're also, this language to look at these lists is included in some of your sub-provider or your subcontractor contracts to require them to do it as well. And then it sounded like some counties were even looking at the members to the Mental Health Board or Commission as well. We talked a little bit about KDA funding, for this therapeutic foster care, that it will probably be per diem rate, and that from CMHCA's position, and this is documented in a letter that is posted under the All Directors handouts from December 6th, that this is a change to the state plan that occurred after Prop 30, and so therefore would potentially be subject to state mandated cost claims. So we'll see how that goes, and just kind of where this ends up in terms of funding for the therapeutic foster care. Then we talked a little bit about the 3-year update. On the OAC's website, the documents there are draft, but folks are using them anyway since there's nothing else, and there probably won't be anything else, given that you really should be in the process of developing your 3-year update at this point. We talked a little bit about the approval process, and again, it's no different than probably any other year in that if you already have well, first of all, the only thing the state approves, and that's the OAC, are innovation programs. Everything else is approved by your Board of Supervisors. So as long as you have Board of Supervisors approval, you can go ahead and implement a new program. For existing programs, those are approved, and so you don't need to even really get your board approval to continue operating an existing program. And so then you say, well, we've got to get these innovation programs approved by the state, and that is true. But again, that's just new innovation programs. So to the extent that you have an existing innovation program, you can just continue to operate that program. And I think a lot of this stems from the concern that what if we don't have our 3-year plan approved and ready to go on July 1st? Does that mean funds are going to stop, or we can't continue to provide services? And the answer, I believe, is no. You don't have to have your plan fully approved. But again, the state doesn't approve it. So as long as you have an approved budget from your board, you're probably okay to continue with existing programs. And it would just be new programs that were in the innovation component that would require OAC approval that you would have to hold off on doing. And then the last thing was the CIMH Fiscal Leadership Institute is going to be May 20th through 21st here in Sacramento. There's a link on CMH's website on how to register for that. And so now I'm going to jump into some of the revenue estimates and budgeting. And I'm going to go through each one of these and kind of just tell you where the estimates are looking, and then give you kind of either conservative approach or what I'm calling a more optimistic approach in terms of how to look at those given the data that we know today. So starting off with MHSA, which is the most volatile and most difficult to project in terms of the revenues. Again, very few folks pay this, but I think also that this third bullet is really important to understand, and that's there are 2 sources of deposits into the State Mental Health Services Fund, and 1.76% of all monthly personal income tax payments go into the fund on a monthly basis. So regardless of whether you're a millionaire or not, 1.76% is going in of all personal income tax payments, basically to provide some cash flow to the fund. And then there's a settling up with an annual adjustment that lags by 2 years based on the actual amount of funds earned by this tax. And that is then the annual adjustment, and it lags by about 2 years. And so beginning in 12-13, you started seeing funds on a monthly basis. Prior to that, you had these published amounts that you basically had to apply for, and they distributed those in various ways, quarterly or 75% at the beginning and 25% at the end. But now every month you get a check, assuming that there's sufficient funds in the State Mental Health Services Fund, based on the unspent and unreserved monies in the State Mental Health Services Fund. This next bullet is critical to understand that the cash transfers, so that 1.76%, those are largest in months when there's quarterly tax payments made and year-end tax payments made. So those cash transfers are largest in January, April, June, and September. And those are then distributed the 15th of the next month, by the 15th of the next month. So what that means is you look at that, 3 of those months are in the second half of the fiscal year. And so this is very much a backloaded distribution to counties, purely just based on when the timing of the estimated payments. And then we've got these annual adjustments that are incredibly volatile. They lag by 2 years. We know them by March 15th, which is nice, so we can kind of plan for it. And then it's deposited on July 1st. And so again, depending on that annual adjustment is going to dictate significantly the amount of funding that you're going to receive in the first half of the year. And then the governor's budget is the primary source for a lot of these projections that you're going to see. I had a couple of other points I want to make. So previously, I thought, based on data that I had, that 15% of the 12-13 component funding was from prior year state mental health service fund deposits. It turns out that more was from prior year in 12-13, which meant the revenue for 12-13 was less than I had thought. Part of that had to do with this next bullet, which is the state didn't encumber funds for workforce education and training. And so they released those funds as if they were unspent and unreserved funds, in 12-13. And so you folks actually received more money in 12-13 than you should have. The downside is, in order to meet those WET obligations in the 5-year workforce education and training plan, it means that as revenues come into the fund now, they're basically going to repay those prior year encumbrances. And so it lowers the amount of future year funding that is available for the 3 components that are left. In this current year, probably more so than, well, every year, January and April deposits are very critical, because what you have in January with the estimated taxes are folks that now know how much money they received in the folks that pay the estimated taxes. They know how much money they received in the calendar year, and generally I'm going to guess most of them try to make an estimated payment in January to pretty much cover that liability. And then April's always big, just because you have everybody paying in any amounts that are owed. So those 2 months tend to be even more critical than the other 2 estimated tax payment months. This January was even more critical, because last January we had a couple of tax law changes that resulted in a huge amount of collections in January. And that was the change to the capital gains at the end of 2012, and then the implementation of Prop 30, or the passage of Prop 30, which brought way more money into personal income tax payments into the state in January than typically would have been expected. And so whatever those amounts end up being this year are going to probably dictate how much your 13-14 distributions are. And then actually we do have the information notice here that provides the individual county allocation percentages. So looking at this, most of this is from the governor's budget. So I basically interpret what the governor's budget has, and it's based on an OAC financial report that they put out in January and then again in May. This, I think, is probably, if anything, a little optimistic. Looking at the 12-13 cash transfers versus 13-14, again, because of the large receipts in January of 2012, I don't know if we're going to actually hit that amount for 13-14. And in fact, right before getting on the call, I looked at the State Controller's Office website, and they did indicate that personal income tax payments were about 20% lower this January versus last January, which to us, ballpark, is probably about $40 million or so. So I do think, unless April ends up coming significantly higher, that the target of keeping this flat is probably not going to be met. And then the other part you'll notice in this is that these annual adjustments are projected to be significantly higher than these actual ones that were 12-13 and 13-14. They're projecting $273 million that we'll know this coming March, and then that would be deposited this July. But I want to point out that at this same time last year, they were saying that this 13-14 adjustment was going to be about $260 million, and then when they actually did all the number crunching and settling up, it was only $153 million. So, it's on there, but I'd be a little cautious as to whether that's going to actually materialize. And then I lowered this. I think the state had about $380 million. I don't know if that's going to actually materialize out in 16-17. So what does that mean? It means that here would be the estimated component funding for current year, in the next couple of fiscal years as well. And this is definitely down from prior projections, again, based on the cash transfers just not coming in, and having to set up to factor in that workforce education and training needs to come out of current and future year revenues. These estimates factor that into them. So that's the estimated component funding for the next couple of years. You can see it graphically there. We peaked up here in 12-13, going down quite a bit in 13-14, and then we'll start to probably see an increase. But really, you start to look at what's sustainable, and I'd probably be budgeting at the 14-15, 15-16 level. So then again, going into some budget considerations to hopefully help you as you prepare your 3-year plans as well as your local budgets. I think conservatively, we're looking at about a 25 to 30% reduction in distributions in the current fiscal year compared to 12-13. And so again, and we've provided the link there for the 12-13 if you need to look up how much the State Controller's Office says you received in 12-13. Optimistically, maybe it'll only be 15 to 20%. But to be honest with you, based on what I just saw, which was after I'd already put this together, I think it's going to be more in that 25% sort of range. I think it would have to take a really strong April tax collection to get down to a 15 to 20% reduction compared to 12-13. And then looking at 14-15, if you want to go conservative, I'd say a 5% increase from 13-14. And what that's really doing is taking, like I said, that annual adjustment that the state is projecting to be fairly significant and saying, well, maybe that's not going to be realized. And so let's go conservative and say maybe we're going to be looking at about a 5% increase over whatever we estimated for 13-14. Optimistically, if that annual adjustment comes in, then you're looking at about a 10 to 15% increase from 13-14. So it just depends on where you want to go. And then looking at future years, you conservatively could say, hey, let's just kind of keep it flat after 14-15. We don't know where the annual adjustment's going to go. We probably will see some growth in the cash transfers, but let's just not show much in terms of growth. Optimistically, I think there might be a little bit of growth in 15-16, and then a potential larger increase in 16-17. I do think that we will start to see some larger annual adjustments, similar to what we saw back in like 8-9, where we saw about a $500 million annual adjustment. But I'm not sure if I'd be pushing that out at this point, or at least I would not want to have to rely on that income to make ends meet in those future fiscal years. So that's MHSA. Anybody have questions on MHSA? All right. Let's talk a little bit about the 91 realignment. Again, here's just some background. It refers to the realignment that occurred back in 1991 when counties took on the responsibility for mental health, social services, and public health services. There were some specific taxes dedicated for the 91 realignment, and that was all fine and dandy until 11-12, when the state decided to do a swap of the CalWORKs maintenance of effort that was funded with state general fund with our mental health realignment. So in other words, the funding that used to come into the Health and Human Services realignment account that was for mental health, now beginning in 11-12 went to this CalWORKs maintenance of effort. And what they did was take a little bit of the 2011 realignment, which I'm going to cover in a minute, and say we're going to go ahead and give that to fund the 1991 realignment obligations. So in 11-12, they guaranteed us a little over $1 billion. And then in 12-13, the way that it's set up is that it's a guaranteed minimum amount of funding for mental health at the $1.12 billion. And then to the extent that there is growth in the mental health account of the Health and Human Services account, that once that growth hits that $1.12 billion, or the overall amount transferred to CalWORKs MOE hits that $1.12 billion, then the growth starts to come to the 1991 account. So we're kind of waiting there. I didn't put down the numbers from last year. I want to say it was in the 980 sort of $1 million range. There was pretty significant growth, maybe even a little bit more. So once that 1.12 billion gets hit, then we will start to see growth in this sub-account. The other part of this that's kind of a little twist is that in addition to that growth, we also get 5% of the annual growth in the 2011 realignment support services account. And so it's kind of just 5% off the top in terms of what went into that growth, the support services growth account. And so, but it doesn't impact our base funding. So it's almost more something you want to look at, not to fund ongoing programs, but maybe something to fund reserves. So in terms of estimated funding, you can see this here is what this is all from the governor's budget, which pretty much assumes about a 5 to 6% growth in sales tax. Actually, I think even in 14-15 it might be a little bit more than that. So you can see we just basically, last year we got 1.12 billion. This year we're anticipating the same. 14-15 we do anticipate maybe at the end of this year there might be a little bit of growth in 13-14. I don't think I'd budget for it. But then in 14-15 we do anticipate there being some growth, but again, that's not known until 15-16. So I wouldn't be budgeting for it in 14-15. And then you can also see again at the bottom the estimated 5% of the growth in the support services account that would then go into this account as well. So what to think about in terms of realignment, the 1991 mental health realignment budget. I don't think there's any reason we wouldn't see the taxes. Well, actually, it doesn't matter. In 13-14, we're going to get the same amount that we received in 12-13. So go ahead. You can see, again, we've listed the link for the 12-13 amount that's on the SCO website. That's the amount I would budget for the current fiscal year. And then we know that in 12-13, 10.7 million was received as growth that should go to the 91 account. They just haven't distributed it. And so I would anticipate receiving whatever proportion you receive of the 91 account, that would be your share of the 10.7 million. And I would think you're going to see that hopefully in the next couple of months. For 14-15, same thing. I don't know if I would be budgeting any more than you're going to receive in the current fiscal year, which is the same as what you received last year in terms of your base amount. Then you'll see a little bit of this one-time growth, this $8 million. For probably most of you, that's not going to be a whole lot of money. But at least I think conservatively, you're going to get some of it. Optimistically for 14-15, and really this isn't 14-15. Optimistically, I think for 15-16, optimistically we'll see a 6% increase in 14-15 that would impact the base for 15-16. So you'd really be budgeting a 6% increase in 15-16, not in 14-15. But again, the way that the growth works, because it's not known until you're into the next fiscal year, it's kind of a double bonus. It increases your growth for the increases your base for the fiscal year in which you are in, plus you get a check for the growth for the prior fiscal year. So it's kind of a nice thing. But again, I wouldn't be planning on that. It may occur in 14-15, but you wouldn't actually see the cash and know it until we're into 15-16. Then going forward, depending on what you think sales tax is going to do, again, the last couple of years, or at least the last year, we're currently, this year to date, we're up about 6% for the first half of the year. So conservatively, 1 to 2% growth based on growth in sales tax with kind of a 10 million mark as this one-time amount from the 2011 account. Optimistically, maybe a 5 to 6% increase in the annual base beginning in 15-16 with 10 million distributed as the one-time amount. So it definitely looks positive going forward, but we're probably going to be stuck at the current amounts, at least for current year and probably budget year. Anybody have any questions on those?
Here's a question. Will the 5% coming from 2011 realignment to 91 mental health realignment be distributed to counties according to the normal 91 realignment allocation schedule?
So we don't know, but CMHCA's recommendation was to do exactly that, because this relates to the 91 account. Even though it's funded from the 2011 account, it has nothing to do with the services and the obligations of the behavioral health sub-account on the 2011. So hopefully the state doesn't try to do something with that 10.7 million to deal with some of the issues on the behavioral health sub-account side, because it's really a 91 an amount for the 1991 account. So that we're hoping that it's distributed. You can go to that link, look at your percentage of the total from 12-13, and hopefully that would be the same percentage you would receive of the 10.7 million, one-time stuff. All right. Moving on to the 2011 realignment. And again, we've talked a little bit about this already. The additional realignment occurred actually as part of the 11-12 state budget, although mental health wasn't incorporated until 12-13. It dedicated a specific revenue to the services. It's basically, from our perspective, it's all sales tax money. There's a little bit of VLF that goes to a law enforcement program. And these are all services that were previously funded with state general fund dollars. And then, as you probably know, in 11-12, they actually took MHSA money to fund the realigned mental health services. So, even though we were part of the 11-12, we really weren't part of this new sales tax in 11-12 and really didn't get folded in until 12-13. There was, and again, I talked about this briefly, in the January distribution that just occurred, there was an adjustment that was called the SB 1020 adjustment. We believe that was purely for cash flow and should not impact your base. So it just means, because the revenues are growing, sales tax is growing, we'll hit the base. They were just distributing it to the behavioral health and actually to the support services and everything. They were just putting too much money into our account, more than what was consistent with the statute. And so what do the revenue projections look like for this? Again, this is all from the governor's budget. And really, you see that nothing's really changing up here, because technically these programs, with the exception of the residential treatment, is in statute at a flat 5.1 million. The rest of this is it's part of the behavioral health sub-account. It is technically up to you how to decide how to use those funds for these services. But what you see, 1213, like I said before, this is basically what was used to figure out what the base looked like for each county in 1213, these different programs, these different amounts, with the exception of the residential treatment, which is, there's only about a handful of counties that are part of that, and it's actually carved out now of this, of the behavioral health subaccount. And so going forward, we're not sure if they're going to continue to try to do this sort of level of detail, or that really the focus should be on these growth amounts. So like I said before, there was $27.8 million in growth in 1213. That's then added to the base amount, and that then becomes the new base amount for 1314. And so then there's a projection of $52.8 million in growth in 1314. That then becomes this new base amount for 1415. And I think you probably would typically want to lag by a year in terms of how you're budgeting. The other thing that you'll start to see is that we're kind of just going along with basic growth that kind of mirrors the growth in sales tax. It doesn't totally equal the growth in sales tax, because some of the other accounts, in addition to receiving a growth based on the percentage, based on the revenues that were received in the prior year, they're actually getting a bump in their growth until, like, for example, child welfare hits an additional $200 million. Once that happens, all of a sudden the share of growth that's going to the behavioral health subaccount changes, and we start to get more growth. So that's why you see a huge bump in growth in 1415. Again, recognizing that even though the growth is associated with what's earned in 1415, we really don't know it until 1516, and it then impacts your 1516 base. So again, some things to think about as you go through budgeting for the behavioral health sub-account. So again, I to start with, I take these percentages that were in this letter, and I would apply those to the new base, the 1314 base of $987.1 million. Again, the reason, so how you get to the 987.1 is, and the reason it's not 992.2 is because this 5.1 isn't a part of those allocation percentages. So apply those percentages in that letter to the 987.1, and I, you know, again, sales tax is up 6%. I don't think there's any reason that we would see a decline in sales tax at this point. I mean, even if it's flat for the rest of the year, we'd still be up, you know, 2-3%. So there's a really good probability that we're going to hit, you know, hit the base for 1314. So I think conservatively, even using that figure, we'll hit the base. You know, optimistically, I don't think you're going to want to budget anything more than that. The one thing I didn't put on here was that you are, again, going to get the 1213 growth will be distributed in the current year. And so, you know, if you wanted to, you could also add that to this. But in terms of your base, I think it's going to be, whether you're conservative or optimistic, it's going to be the same for the current year. For 1415, you know, again, conservatively, I'd keep it at the same amount as 1314. If you want to be a little bit more optimistic, you could take those percentages in the Department of Finance letter and apply that to the new base for the estimated base for 1415. Which again, if you go back here, the new base for 1415 is going to be the total amount from 1314 less the $5.1 million for residential treatment. And so that would be how you would get your 1415 base. The one caution on that is, again, we don't know actually how these percentages were calculated. We don't know if they're going to do something similar in 14-15 or for 14-15 that could result in some counties gaining and some counties losing. Again, from CMHCA's perspective, we've said, let's just keep it constant, keep the base constant, and if you want to mess with anything, mess with growth in terms of, and then that growth should establish the base for the next year. But we'll see how that goes. And then in future years, again, we're probably going to see a pretty big increase in the 15-16 base. Whether it's 10% or 17%, depends on whether you anticipate sales tax going up 6 to 7% a year, or do you think it's going to be in more the 2%, 1 to 2% a year? But still, in either case, we're probably going to see a fairly significant increase in the 15-16 base, and then it's just a matter of how you anticipate base to grow each year after that. More conservatively, 1 to 2% a year based on sales tax growth, or more optimistically 4 to 5%. And again, that's even less than, I believe, what the state is projecting, which is more around 7%. All right, any questions on this? I know it's kind of confusing, but
there is a question. How will the prior year growth be distributed? Will it be included in the base amount or held separate? Will it go into the growth account or the behavioral health sub-account?
So the growth, so the 12-13 growth plus the 12-13 base equals the 13-14 base in total for the behavioral health sub-account. What is different in the behavioral health sub-account from the 1991 realignment account is that the state for 13-14 in some cases fairly significantly changed the percentages that each county gets of the base. So for an individual county, you can't take a look at what you received in 12-13 and think you're going to get that amount in 13-14. You also can't take a look at what you received in 12-13 plus whatever they end up distributing to you as growth from 12-13 and expect to receive that in 13-14. I think your best bet is to take those percentages for 13-14 and apply it to the base for 13-14, and that should give you a pretty good idea of what you'll receive in 13-14. Again, at this point, what CMHDA has said is to distribute that $27 million in growth here for 12-13 based on, and I'm not sure if we were specific about whether it was the 12-13 or 13-14 percentages, but just to get that money out because it isn't impacting the base of an individual county for 13-14. We're hoping that going forward that they start to operate this behavioral health sub-account similar to the 1991 sub-account in that, yes, whatever you received as your base in the prior fiscal year, you're guaranteed that amount as long as there's, sufficient revenues to cover that, as long as there's at least, a little bit of, or flat or a little bit of growth in sales tax. We're not there yet in terms of, a policy decision from the state. That's why it's so weird, and it's got to be frustrating for you guys. It's frustrating for me. So, all right. Any other questions?
Could we please get this information in writing? Just a bit confused about how to calculate the base.
So for 13-14, we're waiting for the information notice from the state. And so once that comes out, I think we can just use that. All right. Moving on to the mental health, Medi-Cal, especially mental health reimbursement. You guys are probably aware of this. You're reimbursed based on, ultimately based on your certified public expenditures. You're paid an interim amount based on approved claims. Those are reconciled against what you show through the year-end cost report, and then the state audits the cost report. A couple of things that changed. We eliminated the SMAs beginning in 1213 as part of AB 1297. We've already talked about the supplemental state plan amendment, which will allow you to claim for certified public expenditures above the SMAs that were applied, and that will go retroactive back to January 1st, 2009. And then, the Affordable Care Act that took effect January 1st gives you, there's really two pieces to it. The mandatory expansion, which is based on that there are people who are eligible for Medi-Cal and have been eligible for Medi-Cal that hadn't applied for Medi-Cal previously that they anticipate now applying for Medi-Cal. They're going to qualify under one of the prior existing aid categories. They're reimbursed at 50%. And then really the main one is this optional expansion, which is a new eligible group, and those you'll get 100% initially reimbursed. And so this all comes from the state budget. Actually, the Affordable Care Act doesn't, but the existing specialty mental health services and the supplemental payment state plan amendment do. With the supplemental state plan amendment, they're assuming that the second half of fiscal year 08-09, all of 9-10 and 10-11 will all be paid out in the current fiscal year, and that amount in 14-15 under the supplemental payment state plan amendment is just for 11-12. And then the Affordable Care Act is really just a guesstimate. Looking at some of the data, recognizing that we only have half a year of implementation, so probably in the current fiscal year, it's mainly going to be focused on existing clients that are now covered at 100% FFP. So just some things to think about. Your existing FFP, however you do that now, really isn't going to change for the existing program or the program that existed prior to the ACA or the supplemental state payment plan. But really, it's more, so I can kind of tell you how I would look at the supplemental payment state plan amendment and the ACA. I think for current year conservatively, I think there's a high probability that you're not going to get paid anything for the supplemental payment state plan amendment in this fiscal year. That by the time the state works it through with CMS, gets the forms out, I think there's a high probability you're not going to see much. And then looking at the ACA, the impacts, again, unless you've expanded capacity, I'm not sure if you're going to see much more than just FFP that is now available for some of your existing clients. Optimistically, if the state works quickly, maybe we'll see it for the supplemental payment state plan amendment for the second half of 8-9 and 9-10 as part of that settlement process. And hopefully you've all gone through and looked at your cost reports, your filed cost reports, and have an idea of how much this means to you for each fiscal year, the supplemental payment state plan amendment. And then, under the ACA, there's a chance if you've expanded capacity that maybe you will see more than just your existing clients, and you would see some additional FFP for new clients. But that's probably going to be driven by your capacity more than anything else, and the outreach efforts that you're doing locally to expand services. For 14-15, I think conservatively they will have this in place by then, and that they'll cover the second half of 8-9, 9-10, and 10-11. I don't think they're going to be able to reconcile 11-12 as part in 14-15. And then I think I would start to anticipate some impact of the ACA is your existing clients plus whatever sort of expansion efforts you're looking at for some new clients. And then optimistically, they'll cover the other 2 years of the state plan amendment, 10, 11, 11, 12, and the same thing on the ACA. And then really, it's future years. Again, this is that whole feasibility system study where short term, meaning, probably beginning maybe in 15, 16, and lasting through 17, 18, 18, 19, we'd be looking at a new reimbursement approach, probably a quarterly payment approach that tries to result in interim payments that are more closely approximate to what your actual costs are going to be, and therefore lowers your settlement amounts in future years. So we start to get an interim payment process that is pretty close to where you should be when you settle. And then longer term, a different reimbursement approach, whether that's in 17, 18, or 18, 19, where we start to look at either case rates or capitation rates. And case rates being where you're reimbursed based on the clients that receive services, and it would obviously vary by levels of service and so forth, the case rates, while capitation payments is based on folks that are enrolled regardless of whether you provide services. And again, that would probably be risk adjusted based on the different aid code groups, ages, sex, a lot of demographic data. So, but that's kind of a ways out. So that's it on the Medi-Cal, especially mental health. And then lastly, just wanted to at least touch on this. There are, as we mentioned previously, some state general funds in the budget for drug Medi-Cal services beginning in 13-14. They had $28.2 million in state general fund for residential services and $10.5 million for intensive outpatient services in 13-14. Basically, those amounts are pretty much just double then for 14-15 since it's a full year versus a half year. In the Financial Services Committee meeting, DHCS indicated that the state general funds would be allocated probably based on existing drug Medi-Cal providers and population mix, but that didn't make sense given the issues that they're talking about with the claims. So I'm going to guess that they're going to use the approved claims to actually determine how much state general fund goes to each county or each provider. The other thing that's interesting about these supplements, when I talked about the budget supplements that they put out for drug Medi-Cal and especially mental health, is that the 13-14 and 14-15 for that matter, supplement for drug Medi-Cal shows a decrease in the drug Medi-Cal base over what was used to establish the original percentages in the 2011 behavioral health subaccount, and fairly significantly. So, there was 131 million used to establish the 12-13 behavioral health subaccount base percentages, but now they're showing only 92.8 million is needed for drug Medi-Cal services in the 13-14 budget. So it's unclear whether the state will use this data to try to redo the behavioral health subaccount percentages. And this is on top of the Medi-Cal, especially mental health supplement, showing a fairly significant increase in EPSDT. So that's why I say there's still a lot unknown on all of this, unfortunately, even for the current year around the behavioral health subaccount. But I did want to point that out for you. And that is it. And I think we're out of time, but I'll take any questions, I guess, at this point.
There's a question. Would SB 82 be included in the MHSA 3-year plan as another component or completely different like the SAMHSA grant?
So so first of all, SB 82 is the triage grants that the OAC just recently awarded. Those technically are funded with MHSA state administrative funding. So they're not a component funding. That said, I would imagine, the OAC has to come out with some guidance. I would imagine they're going to ask for a contract or would issue a contract that would specify the terms and conditions of the grant. but I would think you will be tracking it separately. I would not think it would be part of your 3-year plan, but because again, it's kind of outside of the regular components. It's not a local assistance, which is how CSS and PEI and innovation are funded. So I don't think it would be part of it, but I mean that's speculation at this point. But I would think that you're going to have to track it separately. You're going to have to identify any FFP associated with it separately. You're probably going to have to identify any FTEs, any positions associated with it, since SB 82 was very specific about the number of people to be funded with it. But again, OAC needs to come out with some sort of guidance, which again I would think would be through a contract with you specifically for these grants.
No more questions so far.
All right. So is that it? What I had originally, yeah, go ahead.
No, it looks like that's it. Great.
Again, so we had there's a couple of follow-up things. We will get you links to DHCS's Medi-Cal estimates website. We'll get you links to the CSI and DCR website, and then links to. We'll take a look at the information notice regarding Medicare Advantage plans and see if that is related at all to Drug Medi-Cal, or if you have that option for Drug Medi-Cal, and we'll get back to you on those. Yeah, and so if that's it, then thanks for listening. I apologize for the confusion, but a lot of this is just so much is unknown, and so this is kind of the best we can do at this point.
Thanks, Mike. And the next one of these calls will be March 10th, I believe.
Yes.
Right. March 10th,
right.
From 1 to 2, I think. All right. Thank you. Thanks, everyone.
Thank you. Bye-bye.
Bye.